stocks, and restoring and reinforcing existing supply chains as soon as possible after a crisis. Before we get started, I just wanted to present a couple of housekeeping points. So if everyone can mute yourself unless you're speaking, and please put your questions in the chat box. You can type your question anytime, but we'll wait until after the presentations to do the questions and answers. And it would be great if you can put your name, if that's not already apparent, and your organization. And then at the end, I will read the questions from the chat to the panelists. If I miss yours and you really want an answer, feel free to take yourself off mute and ask. So just to let everyone know, we are recording the webinar, which I will do right now. Sorry, and now I'm going to hand this over to John Townsend. He is the board chair of the Reproductive Health Supplies Coalition, the chair of the Population Council's Ethical Review Board, and a persistent voice in support of human rights in the SRHR space. So over to you, John.
Thank you, Elizabeth, and welcome everyone around the world, friends and colleagues, to this webinar on a critical issue for the 21st century. I recall speaking with a Ministry of Health official after the earthquake in Highland, Guatemala in 1976 about what to do about unsolicited clothing donations that were coming in, high heels, fancy sweaters, while food lay unattended in the docks. Later in 2005, I recall speaking with the Tulane University authority about the focus after Hurricane Katrina about rescue and shelter without really thinking systematically about SRH needs, deliveries, regular medicines, contraception, menstrual products. And more recently, I've noted the support in Pakistan that the UN provided through MISP and GPS mapping so that teams could work collaboratively with communities to resettle out of flood zones during the monsoon. But they also thought about bringing the health workers along with them. So this is really a community and integrated approach. A lot has changed in the last 45 years, but much more needs to be done to ensure access and long-term reproductive justice. What are the elements to consider in developing these recommendations? I think there's four that come to mind for me. The first is scale. UNFPA, estimated that there were about 136 million people affected by humanitarian crises. Some of these are short, some of these are long, but the effects certainly are prolonged over time. The second issue is really diversity. These conditions are present in over 64 countries with diverse language groups, ethnicity, and diverse needs of those affected. This moves from small villages affected by, let's say, the violence in northern Nigeria to 1 million Rohingya in Bangladesh. The third issue is kind of duration. We have to respond to the short-term immediate needs for relief, but also the long-term resettlement issues due to political issues. Look at the Palestinians in Jordan, which have been there since the late 40s. And finally, there are competing interests, whether it's COVID-19 or economic demands and the perceived burden of refugees. These are all in competing conditions for resources, for policy space, and for engagement. What is clear, though, is that we need to think as duty holders of the Nexus as both serving individuals for their protection and preserving their rights to sexual and reproductive health, as well as thinking at scale to ensure public health good. What is required is clearly outlined, I think, in the policy paper that you received. Pre-service preparation in supply chains, and here I'd like to kind of highlight the need for visibility and the needs of both providers and clients. Crisis response, clearly, post-crisis transition to recovery, and above all, the need to cooperate for cooperation between governments, donors, implementing agencies, humanitarian groups to eliminate fragmentation, ensure we use evidence and information to ensure continued supplies, and to ensure reproductive justice overall. We look forward to the results of this webinar for better outcomes for individuals and the promise of more just societies globally. Welcome and enjoy the seminar. Bye.
Thank you so much, John. Next, I'm going to present today's speakers. Perfect. So Sarah Rich is the Associate Director for Sexual and Reproductive Health at the Women's Refugee Commission. She co-chairs the IWAG Supplies Sub-Working Group and leads a project in conflict-affected northeastern Nigeria, partnering with government and other local actors to implement community health programming. So today she will launch a joint advocacy brief that was developed by the Reproductive Health Supplies Coalition and the IWAG that contains specific recommendations for building resilient SRH supply chains. Next up is Bronwyn Miller. She is the Regional Humanitarian Project Coordinator for UNFPA's Asia Pacific Regional Office, where she manages a regional humanitarian preparedness initiative that is focused on prepositioning of SRH and GBV supplies. So she will discuss learning from UNFPA and DFAT's Asia Pacific Regional Humanitarian Preparedness Initiative and show a short video. And the third person in our lineup today is Frank Roymans. He is the Senior Supply Chain and Reproductive Health Programs Advisor at iPlus Solutions, where he focuses on last mile availability of family planning commodities in Francophone African countries. Prior to that, he was responsible for family planning access program for low and middle income countries at MSD and Organon. He will discuss revitalizing supply chains and logistics for SRH commodities up to the last mile in DRC. And unfortunately, we had planned for another person to join us, Nicholas Jeske from Help Logistics. I'm sure I've murdered his last name, so my apologies, but he will unfortunately not be able to join us today. Okay, so with no further ado, I will be handing this over to Sarah.
Thank you, Liz. And thanks, John, for your introductory remarks. Those were great. Thank you. So as Liz said, I'm going to be launching a new supply chain advocacy brief that was developed collectively by the IWAG and the Reproductive Health Supplies Coalition. And I've listed here the 5 key authors that worked on this document. I'm presenting on behalf of this group. So that's me and Liz, who's moderating, Charlotte Sulery from RHSC, Leila Aklagi from JSI, and Sarah Stratton from Palladium, all of whom have various roles in IWAG, leadership in the IWAG and the RHSC. So I'll be launching this on behalf of everyone. We also had quite a number of people review and provide insights and ideas to the brief, but I'm not able to recognize everyone here. Next slide, please. So the grounding kind of aim within this brief is that supply chains for sexual and reproductive health must be resilient to shocks like humanitarian crises. And the first reason for that is that these services, SRH services and supplies, are needed in both stable and crisis settings alike. So whether you live in a setting that is generally stable or in a setting that sometimes faces natural disasters or can be vulnerable to conflict, the women and girls and gender nonconforming people who live in those settings need access to SRH services and supplies alike, no matter where they are. And then another grounding factor within this brief is that there's actually an interplay between what happens during stable times and what happens during crisis times. So we see that all countries, in fact, are vulnerable to emergencies. And I think that's never been so clear as it is today, about 7 months after the COVID-19 pandemic started to really pick up globally, that all countries really do need to take consideration what they're going to do and how they can prepare for a crisis. During crisis times, we also see that this lack of SRH supplies has been documented multiple times as a critical gap. So we do know that when countries move from stable to crisis, we see this gap in access to SRH supplies. And beyond that, we also know that when crises strike, they disrupt the gains that have been made during stable times in access to SRH services and supplies. And not only do they disrupt them, but they can take them back. They can derail those gains. So we need to build resilient supply chains for sexual and reproductive health that can withstand and adapt to and recover from shocks and crises like COVID-19, like natural disasters, and like conflict. And we need to do this in order to maintain continuous operations and delivery of health products for women, girls, and other marginalized groups that live across both stable and crisis settings alike. Next slide, please. So to provide a little bit of background, I wanted to take us back to a previous information brief that was co-published by the IWAG and the RHSC, along with several other organizations that you can see. This brief laid out a number of activities that can be done to better prepare for crises, including creating enabling policy environments to facilitate rapid entry of products during crisis times. So that would be things like including products that are in SRH emergency health kits in national essential medicine lists and ensuring that all of those products are registered. Then that includes mapping out likely needs, challenges, and contingencies along the supply chain, strengthening national human resource capacity to manage SRH supplies during emergencies, integrating SRH supplies that are used during emergencies into logistics management information systems, improving coordination mechanisms across partners, and decentralizing stock or pre-positioning key supplies when strategic. Next slide. And can I ask everyone to mute? It looks like we have a person who is not muted. Or maybe Erin can use co-host powers to mute that person. Sorry. Then on the other side of crises, of an acute crisis, during a protracted crisis response and recovery, there are also a number of activities that are outlined in this information brief. So preparing to decrease reliance on the emergency health kits by conducting detailed assessments of the supply chain systems, gaps and capacities, as well as coordination mechanisms. Strengthening human resource capacity again across partners to transition from emergency supply chains to more stable supply chains. Strengthening logistics and supply chain data collection and really using it to inform supply planning and forecasting. And strengthening the infrastructure for the national supply chain. Next slide, please. So building on all of those activities that were laid out in prior brief, this advocacy brief that we're now launching calls for collaborative action for resilient supply chains through governments, donors, and implementing partners working together in the humanitarian development nexus. And I know kind of this question of what is the humanitarian development nexus is one of those questions that is often coming to the forefront. What does it even mean? Is it just jargon? So what we'd like to do here is lay out what do we mean specifically when we're talking about the humanitarian development nexus with respect to supplies for sexual and reproductive health. So here in the middle, you can see a diagram that actually shows the emergency programming cycle. And on the right, we have pre-crisis preparedness. So preparedness, that was that first list of activities that I showed, is part of the humanitarian development nexus because emergencies seem sudden, but they can actually be predicted. And preparedness during stable times is what can help supply chains adapt to and withstand shocks. So then moving down, we have the acute crisis response. That's really where humanitarian actors come in, as well as local governments, local actors. But this is not what we're considering the humanitarian development nexus because this sits more squarely in the humanitarian sector's field. Then moving along, we see on the left the post-crisis transition. So this is the other part that's part of the humanitarian development nexus. After an acute emergency hits, more robust services and supply chains should be restored that are responsive to the specific demand within the population that's been affected and that meet longer terms. So the brief that we're launching speaks to these two humanitarian development nexus points when it comes to SRH supplies. Next slide. And so here you can see our new brief on the right. That's what it looks like. And at the end of this panel, we will share the links to it, which can be found both on the RHSC and the IWAG websites. And it contains a set of recommendations that were developed jointly by a range of humanitarian and development stakeholders across both the RHSC and the IWAG. It really builds on that co-published information brief that I already showed. And it focuses on these points, as I said, where the humanitarian and development nexus kind of lies. And it's really in line with past global commitments that have been made to improving multi-sector collaboration, such as the Grand Bargain, which is an agreement between donors and aid organizations in which enhancing engagement between humanitarian and development actors is a cross-cutting work stream. Next slide. So the brief lays out asks of 4 different audiences: governments, donors, development agencies, and humanitarian agencies. And it takes those activities that I listed from the previous brief and really makes them more specific and assigns things to different actors as appropriate. So we see that governments in both stable and fragile settings have a role to play in directly preparing supply chains to mobilize quickly when crises emerge, and also in the aftermath of an acute crisis to rebuild those national supply systems. So with that, we ask governments to, on the pre-crisis preparedness side, ensure that the supplies needed to implement the minimum initial service package for sexual and reproductive health are registered, integrated into national preparedness plans and budgets, and included in national essential medicines lists. All of these activities will facilitate quickly getting supplies where they need to go when a crisis does occur. Then, on the post-crisis transition phase, so after an acute crisis, governments have a role to play in sustainably integrating sexual and reproductive health supplies for the displaced populations into their national and subnational processes. So often in a time of crisis, if there's a conflict in a certain part of a country or a natural disaster hits a particular region, those parts of the country can be, are often where humanitarian actors come in. And sometimes what's happening with supply chain processes can be sort of moved out a bit from the regular national and subnational processes. So those areas need to be reintegrated into the national and subnational processes to help transition away from relying on emergency health kits to enable more stable and demand-driven supply chain networks. Next slide. Then we have a couple of asks of donors, and donors really have a key role to play in breaking down the funding silos between the humanitarian and development sectors through using more flexible funding structures and providing leader advocacy on this collaboration that's needed across organizational boundaries. So on that note, we ask donors to integrate emergency preparedness and risk management activities and financing in all SRH supply chain strengthening and other SRH supply investments. So this really means that anytime a donor is funding a supply chain strengthening program, it would be strengthened by a robust integration of emergency preparedness and risk management so that if and when a crisis strikes during the period of that grant or even after, because supply chain strengthening is meant to have long-term impacts, the supply chain will be ready to adapt to and recover from those crises. Then on the post-crisis transition side, we ask donors to invest in supply chain strengthening interventions for sexual and reproductive health in a range of protracted crisis and recovery settings, and in builds the evidence base on what works. So that really looks like taking some of the supply chain strengthening interventions that have already been implemented across a range of stable settings and providing the funding to adapt and apply them in crisis-affected settings, particularly in protracted crisis and recovery settings, so that we can build an evidence base on how best to restore supply chains to pre-crisis stability and normality. Next slide, please. Then we come to development agencies. And here we're really talking about organizations that have long-term SRH programming experience in a particular setting and that are well-positioned, therefore, because of their presence in a country before a crisis even strikes. They're well-positioned to contribute to crisis preparedness and after the acute phase of a crisis to support governments to reestablish and strengthen SRH supply chains because they have that technical expertise from years of operating in these settings and conducting and supporting supply chain strengthening activities. So in the pre-crisis preparedness phase, we ask development agencies to integrate emergency preparedness and planning activities and budgets into all SRH supply programming and to support governments to include SRH supplies in their emergency preparedness planning and budgets. So this, as you can see, this really aligns with some of the prior asks across the other audiences. And then in the post-crisis transition phase, we ask development agencies to apply and adapt their supply chain strengthening evidence and tools that they have used in stable contexts to help facilitate a return to comprehensive, sustainable sexual and reproductive health service delivery in these settings that have been affected by a crisis, but that are no longer in the acute crisis moment. Next slide, please. Lastly, humanitarian agencies. Humanitarian agencies have a role in rapidly responding after a crisis with surge capacity, which is deploying staff with additional expertise within a particular location. But they also have a role to play in pre-positioning sexual and reproductive health supplies, and then in the aftermath of an acute crisis in contributing to rebuilding or strengthening the existing supply chains rather than working through parallel supply chains. So we ask humanitarian agencies to, in the pre-crisis preparedness phase, to participate in global, national, and subnational SRH technical and commodity security working groups. And here we're really talking about these standing working groups that are often led by people who sit more within the development sector or who work more in stable settings. But there's really a role for humanitarian agencies to play in these global, national, and subnational groups to integrate preparedness activities and support the other stakeholders who are working in these groups to improve their preparedness. Then on the post-crisis transition side, humanitarian agencies have a role in deploying the appropriate human resources, and that includes SRH supply management and logistic expertise in the post-acute crisis response phase so that that expertise is there, and coordinating with government and humanitarian partners through health and logistics cluster to transition away from emergency health kits to procuring individual commodities and to really support procurement of those commodities through public sector processes whenever possible, again, avoiding parallel systems. Next slide, please. So that summarizes the key asks that are outlined in our new advocacy brief, and we certainly encourage all of you to go visit the site, which again will be shared at the end of this webinar. I can also put it in the chat box. So moving forward, we really see that these fragmented humanitarian and development funding silos and implementation mechanisms don't match the reality of what we see on the ground, where every country is vulnerable to crises and where there is this much greater interplay between what happens in crises and what happens in stable times. And this leads to ineffective supply chains. It leads to waste and shortages alike. So we, the broad set of stakeholders that developed the recommendations in this advocacy brief, so governments, donors, humanitarian agencies, development agencies, as well as private sector and other partners, can collectively develop and implement solutions that have a lasting impact. And to do that, we must come together to collaboratively adapt our actions before, during, and after crises to build resilient supply chains. Next slide, please. So thank you very much for this opportunity to share the new advocacy brief. And with that, I'll hand it over to Branwen.
Thank you so much, Sarah. Can we go to the next slide, please? Thank you. Good evening, everyone. Good afternoon, good morning, depending on where you are in the world. My name is Branwen Miller, and I'm the Regional Humanitarian Project Coordinator for UNFPA's Asia Pacific Regional Office. I'll be sharing a little bit tonight about the Regional Prepositioning Initiative that I manage in the Asia Pacific region. But before I do so, I would like, if you could, Erin, please share the short video that we have on the initiative. Thank you.
UNFPA UNFPA's Regional Prepositioning Initiative has been a game changer in supporting humanitarian preparedness across the Asia-Pacific region. More than 140,000 beneficiaries, affected by 54 emergencies in 15 countries, have received over $1.6 million worth of life-saving, sexual and reproductive health, and gender-based violence supplies. The Regional Prepositioning Initiative prepositions supplies and builds capacity so that the health and protection needs of women, girls, and marginalized groups are met during emergencies. The evaluation of the Regional Prepositioning Initiative found that the project has enabled quicker, more cost-effective responses, is responsive to beneficiaries' needs, which has improved the quality of UNFPA's response, and has positively influenced governments to prioritize sexual and reproductive health and gender-based violence services in emergencies. In Indonesia, UNFPA's Regional Prepositioning Initiative has been a game changer in supporting humanitarian preparedness across the Asia-Pacific region. More than 140,000 beneficiaries, affected by 54 emergencies in 15 countries, have received over $1.6 million worth of life-saving, sexual and reproductive health, and gender-based violence supplies. The Regional Prepositioning Initiative prepositions supplies and builds capacity so that the health and protection needs of women, girls, and marginalized groups are met during emergencies. The evaluation of the Regional Prepositioning Initiative found that the project has enabled quicker, more cost-effective responses, is responsive to beneficiaries' needs, which has improved the quality of UNFPA's response, and has positively influenced governments to prioritize sexual and reproductive health and gender-based violence services in emergencies. In Indonesia, UNFPA's response was 3 times faster and cheaper with prepositioning. Prepositioning can provide value for money by reducing transport and procurement costs. In just 2 years, UNFPA saved $250,000 by transporting supplies by sea rather than air, and procuring supplies through cost-effective, long-term agreements. The initiative has adapted to address the needs of the most vulnerable, with prepositioned supplies customized based on feedback received from women and girls during humanitarian crises. Government partners also agreed that the initiative is responsive to the priorities in their national response plans. The Regional Prepositioning Initiative has helped to ensure that sexual and reproductive health and gender-based violence are prioritized in broader disaster response. Through the initiative, UNFPA has complemented nationally led responses, built the capacity of local partners, and provided technical support that has acted as a catalyst for change in policies and regulations. The findings and recommendations from the evaluation are informing the next phase of the Regional Prepositioning Initiative, thanks to the continued support from Australia.
Thanks so much, Erin. And if you could return to the presentation, that would be great. And to the next slide, please. So to set the scene a little bit, before I go into the Regional Prepositioning Initiative, sorry, one slide back. The Asia Pacific region is the most disaster-prone region in the world. Half of the 281 natural disasters that occurred in 2018 were in the Asia Pacific region, including 8 of the 10 deadliest. 11 of the top 15 countries in the world with the highest disaster risk index are in the Asia Pacific region, and those risks are increasing due to climate change. At the same time, many countries in the region are experiencing conflict and protracted crises, such as in Rakhine, Chin and Kachin State in Myanmar, in Mindanao in the Philippines, and of course, for the past 3 years, Bangladesh has been home to the largest refugee crisis in the world, with 750,000 Rohingya refugees fleeing to Cox's Bazar. All of those 3 contexts that I just mentioned are also highly susceptible to natural disasters. And of course, now with COVID-19, countries are experiencing compounded and overlapping crises that are affecting the availability and accessibility of sexual and reproductive health services. Now, I understand there's a few people on this webinar who haven't worked in the humanitarian space, but I'm sure you can understand that these humanitarian crises disrupt supply chains, damage or destroy health centres, place strain on the health workforce, and make it harder for people to access services at a time when they need them the most. So given this increased frequency, severity of natural disasters, as well as the protracted crises in the region, investing in preparedness, as Sarah has just outlined, is key. Next slide, please. And that is really what the Regional Prepositioning Initiative is. While the name suggests it includes the prepositioning of supplies, it's a preparedness initiative that seeks to improve access and availability of sexual and reproductive health and gender-based violence services during disasters, not only through the provision of supplies, but also through capacity building, strategic dialogues, and advocacy. This year, we held an evaluation of the initiative, which found that the design of the program, whereby there are these multiple connected activities, enables UNFPA to provide both short and long-term support to national governments and responds across the nexus, like Sarah had outlined in her presentation, with UNFPA as both a humanitarian and development agency. This allows for effective dialogue and supports a wider range of change regarding accessing sexual and reproductive health and rights and gender-based violence services. And just next click, please. Thank you. As demonstrated by this quote from the evaluation, the supplies really act as an entry point. Despite being essential and life-saving, sexual and reproductive health is really prioritized by governments and humanitarian actors in emergencies. And our experience now across multiple emergencies in the region has been that being able to immediately come to the table with supplies, sexual and reproductive health is prioritized in the overall response, far beyond the provision of those supplies. Next slide, please. So as you can see from this map, the Regional Prepositioning Initiative has 11 priority countries. They're in red. These are all countries that experience recurrent emergencies, often multiple emergencies every year. So there's little risk of the prepositioned supplies being wasted, but I'll go into that further in the next slide. They're also very diverse countries in terms of geographical, population base, the capacity of national governments. So the initiative is designed in a way that adapts very easily to different contexts. We also have 2 regional hubs, one in Brisbane, Australia, and one in Suva in Fiji, that have prepositioned supplies that can be used across the region as needed. And as you can see, in the last 4 years, we've also responded to emergencies in India, Laos, Timor-Leste, and Kiribati through the program. Next slide, please. As you saw in the video, the prepositioned supplies have reached more than 140,000 direct beneficiaries and 54 emergencies in 15 countries in the past 4 years. One of the benefits of this initiative is that with pre-positioned supplies, we're able to effectively respond to emergencies of vastly different scales, which is in line with UNFPA's commitment to leave no one behind. For example, while we have reached more than 30,000 people in the Marawi conflict in the Philippines with a full range of sexual and reproductive health services, we were also able to support the 10 pregnant women who were relocated following the eruption of the Kadavo volcano in Papua New Guinea, or provide 650 people who were displaced in northern Shan State with contraceptives and STI treatment. Without the pre-positioned supplies, it would not always be feasible for UNFPA to mobilize a response, particularly to those smaller crises. One of the arguments that's often put forth against pre-positioning commodities for humanitarian response, and particularly for pharmaceutical supplies, is that it can increase wastage. And what we've found through this initiative is that well-designed and strategic pre-positioning, that is not the case. Over the 4 years of this project, we have not had to dispose of any of the pre-positioned commodities. We have donated $24,000 worth of supplies to partners for use in non-humanitarian settings when they were approaching expiry and hadn't been used in a disaster. However, that's just 1.5% of the value of the supplies distributed during crises. And for a comparison, UNICEF works to a general understanding that 5% of emergency supplies will be written off. Next slide, please. So just to touch on a few more of the findings from the regional, from the evaluation that was conducted this year. Next slide, next click. Bring up the next part of the slide. So firstly, the initiative has enabled quicker, more cost-effective responses. It makes sense if the supplies are there and on the ground when they're needed, they're going to be quicker than when they have to be flown in from overseas. We've seen this in Indonesia, where using the pre-positioned supplies, the reproductive health subcluster, which is led by the government, had 15 fully functioning reproductive health tents within 2 weeks of the devastating earthquake and tsunami in central Sulawesi. We've also seen that having pre-positioned supplies is essential in contexts like the ongoing conflict in northern Rakhine State in Myanmar, where humanitarian actors don't always have access to displaced communities. So when they are granted access, often at very short notice, we need to have the supplies immediately available so that they're able to provide the sexual and reproductive health care. And then finally, in terms of cost effectiveness, with the suppliers for the reproductive health kits primarily based in Europe, in this region, in the Asia Pacific region, during emergencies, we were often paying more for the air freight of the supplies than the supplies themselves cost. However, with pre-positioning, we are able to ship supplies by sea rather than by air. And in the past 2 years, we've saved $250,000 based on the quotes provided at the time of procurement for both air and sea freight. Next slide, please. The evaluation also found that the investment in preparedness through the Regional Pre-Positioning Initiative has improved the quality of humanitarian response received by beneficiaries. This is because we were building capacity of government and partners, and that's a core part of the program, but also because we were collecting feedback from beneficiaries and health workers on the supplies that they were receiving and using that information to inform programming. It was through this process that it became apparent that the needs of people living with disabilities and transgender women were not being met during humanitarian response. And so we have sought to improve this, for example, through pre-positioning dignity kits for transgender women in Bangladesh and people living with disabilities in the Pacific. And this is an area of the initiative we will continue to strengthen. Next slide, please. As I mentioned earlier, the design of the Regional Pre-Positioning Initiative has been flexible, meaning that every year the procurement, capacity building and strategic dialogues components can be adapted based on needs. If there is a need for significant replenishment, we can invest in that. If there are identified capacity gaps, we can focus on addressing those. And that was particularly beneficial this year with the onset of the COVID-19 pandemic. Not only did the disruption to supply chain see pre-positioned supplies being used in Bangladesh, Sri Lanka, Indonesia, Myanmar, and Papua New Guinea to respond to the pandemic following major disruptions to the supply chain globally, excuse me, but we were also able to pivot the program, reprogramming the capacity building funds for procurement and supporting the continuation of sexual and reproductive health services as different countries responded to the pandemic. Next slide, please. Finally, and perhaps most significantly, the evaluation found that the initiative has positively influenced governments to prioritise sexual and reproductive health and gender-based violence programming in humanitarian response. If you could click once more. This is ultimately what decides the sustainability of the program. The evaluation found that UNFPA's comparative advantage is our strong relationships with governments, and the initiative has strengthened coordination and partnerships across the development humanitarian continuum. Building partnerships, especially with governments, requires time, effort, and human resources. But the design of this program, which enables UNFPA to provide both supplies and technical support, has served as an important catalyst for change for policies and regulations. Next slide, please. So we are very pleased to have secured Australia's continued support for the next phase of the program. And they have been an extremely supportive donor to whom we are very grateful. Next slide. We continue to build the evidence base for pre-positioning to influence UNFPA's internal systems. And the evaluation found that innovative programs such as the Regional Pre-Positioning Initiative have the potential to improve internal systems of large organisations, including well-established UN agencies such as UNFPA, by providing the space and opportunity to review and improve approaches, procedures, and systems. And finally, so we have seen that recently in terms of UNFPA looking to pre-position more globally in regional humanitarian response depots, which will enable a quicker humanitarian response in other regions as well. And finally, we continue to work to support governments to ensure the long-term sustainability of the program. And in this regard, we are really thrilled to ensure that the Ministry of Health in Indonesia, has for the very first time made a commitment to use some of its budget in 2021 to pre-position sexual and reproductive health supplies as part of its own humanitarian preparedness efforts. While this still requires parliamentary sign-off, it does demonstrate the benefits the government of Indonesia has seen through the program and their commitment to continue these. And we hope during the next phase of the initiative, we will see this more in some of the other countries as well. And the next slide, please. Thank you. That is the end of my presentation. So handing on now.
Okay, the next presentation will be by Frank Royman. Are you able, Frank, to connect?
Oh, I'm sorry, I was still on mute.
Mute, okay,
Yeah.
thanks.
Thank you very much. Good afternoon, good morning, everybody. My presentation is going to take you to another continent, to Africa. And there, we as I+ Solutions have been working on improving access to sexual and reproductive health commodities up to the last mile. And I will be focusing on Eastern DRC. Next slide, please. In the eastern part of the DRC, we worked over the last 6 years, initially in a project with UNFPA, and later on in a project with Coordate. And this last project that we focused on was Jeunes Espoirs. Hello, excuse me. This last project was called Jeunes Espoirs, and Espoir stands for Sexuality, Security and Safety. This project was focusing on providing access to informed choice of family planning commodities for youth. And we worked on this and from 2016 till 2020. It was in 4 countries, in the DRC, Central African Republic, Cameroon, and Benin. And we focused most of our interventions as a supply chain management partner in the DRC. It was led by Coordate and in partnership with the Ministry of Foreign Affairs of the Netherlands. Next slide, please. So I will start with an introduction on the external environment and the systemic challenges in the health system. And following that, I will give an impression on what we did and what have been the results of this project. Next slide, please. The DRC, and particularly the eastern part of the DRC, is really a very challenging environment. It's complex and fragile. There are large distances to cover. If we look only at South Kivu, there are 2 provinces in which we were active, North and South Kivu. South Kivu only is as big as Burundi and Rwanda combined. So large distances, a poor road infrastructure very often. In the city of Goma in the north, infrastructure has been very well developed, but as soon as you enter into the countryside, and also in South Kivu, the road infrastructure is poor, and also the geographic complexity is significant, which is making it difficult to distribute commodities to the last mile, particularly also when the weather conditions are challenging during the rainy season. In the northern part of North Kivu, and also the eastern part of South Kivu, we see security concerns because of malicious groups that are still active, and so there it is not always easy to get around. There is also quite a significant amount of displaced people, and on top of that, in the northern part, particularly in Beni, the Ebola epidemic has been governing for some years, and now adding also the COVID-19 pandemic. So a very challenging environment to operate. And I will get back to you later on how we have been in these areas where it was difficult to get to, how we have been working and managing our supply chain in spite of all these difficulties. Next slide, please. So this external environment is also combined with a very poor enabling environment from within the health system. As you when we look at report and data exchange, to a high extent, the health system depends on paper-based reporting. The access to internet is very poor, and okay, sometimes it works, but generally we cannot use internet at this moment to exchange data in a reliable manner. So we are using supply chain management tools in order to report. So there are 10 different supply chain management tools that are being used in the DRC. And yeah, that represents quite a significant amount of work in order for the staff at health facilities to use them. And they also need to be aware how to use them. So it's necessary also to train people and to make sure that people are motivated because they understand the work that needs to be done, and also they need to be enabled to do that work in an appropriate manner. One of the things that very often is a challenge is also to move the products. How to get the products from the district or the health zone, as it is called in the DRC, to the health facilities. The budgets of clinics, they are relatively limited. They need to get their income out of their operations. So the transport costs are a burden to them, and they need to pick up the products at the level of the health zones. Every month they need to go back and forth to the health zones in this quite complex external environment. Next slide, please. So what is the result of this external environment? Here I've depicted how the distribution is being organized in the DRC. So goods are being distributed from the regional distribution center to the health zone, which is the district. And then the health facilities, one time a month in principle, one time a month, they are picking up their medicines and family planning commodities that are needed, pick them up at the health zone, and bring them to the back to the health facilities. So there are quite a lot of things that are not working properly in this system. And what is the result? Lack of data visibility of what is going on at the level of the health facilities in terms of stock management, availability of commodities, and also consumption. And also the mobility is an issue because of the fact that there are restricted budgets. The community is assisting health facilities. It's called the CODESA in the DRC. And this community is assisting health facilities in taking care of, let's say, of community-based activities, including also some of the logistic activities, such as checking stock levels and things like that. But all in all, the current system has a problem regarding data visibility and mobility. Next click, please. So what is the result? The result is stock outs, excess stock, expiries, need for redeployment, because if there are too many products in one health facility, they need to be redeployed elsewhere, and high transportation costs. So in the initial project that we did in the Kivus, we had, for instance, a baseline where 88% of the health facilities had too much stock, and 30% of the health facilities were out of stock for at least one family planning commodity that was often used. So a disorganized system that was not really well enabled to function properly. Next slide, please. So what did we do, and what has been the impact? Next slide, please. First of all, we had a small team. You see the team that we had here. They have been taking care as a team in supporting government for in total 11 health zones that covered 3.2 million inhabitants with approximately 150 health facilities. So a small team, And the basis is to accompany the health system. And it was also already mentioned by Sarah also that the public sector processes, they're important in order to ensure access to commodities. And so what we were doing is actually accompany the health system and enabling them to do the work that they are supposed to do. Third element is to align to national policies. So the idea is not to start parallel initiatives in order to get the products where they are needed, but to use the national policies and to implement them. Because in the DRC, the policies, they are very well written. And basically, the entire logistic management information system is well documented. And also, the roles and responsibilities are in principle well defined. The problem is that the enabling environment is insufficient to actually implement them. So that's what we have been doing jointly with our partners at the Ministry of Health. And fifth element is also to coordinate with governments and partners. At the national level it is needed, but also at the district level there is an opportunity for government and partners, including NGOs, to sit down together and to see how we can avoid duplication and improve efficacy. Next slide, please. So what did we do first? First, to get the basics right, because in the system, so we started with a rapid analysis of the supply chain at the level of the health zones. And we found the gaps that were there, and the root causes of why products were not available, or why there was too much stock of certain family planning commodities and medicines. Then jointly with the health zones and the DPS, the province, work plans were formulated in order to improve the situation. And generally, we started, after validation of the training curriculum, we started with a training of trainers in supply chain. That was done at the level of the province and at the level of the health zone. And those trainers, they trained afterwards the staff at the level of the health facilities in managing the supply chain, using the supply chain management tools, reporting timely with the right quality, etc. And then after that, there was this, there was supervision and on the job coaching in order to make sure that the system continued to work properly. So in a stable environment, this is all doable. But when you are in an area like Beni, where you are confronted with most of the things that I mentioned during my introduction, yeah, we were forced to take the staff out of their daily environment and to bring them to Bukavu in South Kivu, where we have been sitting down together, working, developing work plans, look at what was needed in order to enable them to roll out this work plan and to do that jointly within their health zones to the health facilities. And so that is basically the way how we started in North Kivu. We started through the system. So training people, enabling them to do, in fact, the work that we would be doing in a situation of stability, and also ensure that there is a regular reporting on an analysis of the supply chain, and and have monthly discussions. So that was done at a distance. In areas where we were confronted also with safety concerns, there is in South Kivu and also in the north, there is MONUSCO and the NGOs that are working together on safety, which roads are safe to take, what is exactly the situation with regard to Ebola, and the DRC in the eastern part, they are very well organized to exactly monitor what is going on with regards to this Ebola epidemic. And so this information was also shared amongst the various NGOs. And in that way, and we could also, that could feed in our weekly safety reports in order for to know to what extent that our staff could actually go into the field and what the best way would be to go into the field. And obviously with Ebola at some point there was a vaccine, and so also staff had been vaccinated. Next slide, please. So what we did also is, because we had this problem of visibility of data, and also the transport of these commodities. So what we did is basically three things we changed. First of all, we divided the health zones into distribution rounds. They were distribution axes. So for instance, you have 20 health facilities in a health zone. For instance, 4 distribution rounds were developed, and along these distribution rounds, products would be distributed by the health zone to the health facilities. A second thing what we did, that is the star that you see, the red star, is that we started, well, that's the basic thing that we changed, is that we started from a pickup system by the health facility to distribution by the health zone to the health facilities. So instead that each of the 20 health facilities need to make their way to the health zone to pick up products, it is the health zone that is distributing in accordance with distribution rounds to the health facilities. The second thing, another thing that we did was to involve more the community. The community, out of the community, we identified a focal point, an informed push model focus point, as we called it. And that focal point was responsible for each distribution round. So one IPM focal point was responsible for one distribution round. And his responsibility was not only to ensure that products were transported from the health zone to the health facilities, but also the data at the end of the month on stock levels, on requisitions, on consumption, all these data would be reported timely to the health zone. And so the IPM focal point would make its way also passing all the health facilities and picking up the data and the reports. Next slide, please. So what have been the results of this change in distribution? First of all, we did this in 2 health zones. We had an intervention health zone, which was the Katana health zone, and the Walungu health zone was a control health zone. So we started, as you see here, in October 2017, and after the introduction of the informed push model, the intervention health zone rapidly has been growing in terms of availability to 100% of all health facilities, having all family planning commodities available, the 8 family planning commodities that were part of the portfolio of the Ministry of Health. And then in April, you see, in May, you see a dip that's caused by the strike of the nurses. but gradually taking up again quite rapidly to full availability. In the Walungu health zone, in the control health zone, it also improved, but not as significant as for the intervention health zone. Next slide, please. So in terms of stock out and expiries, these also reduced significantly. You see a reduction of stock outs of 88% as compared to the baseline. And in terms of expiries, they reduced by 75% end of 2018 as compared to the baseline. Next slide, please. So another aspect was the last mile transportation costs for family planning commodities that went down by 60%. You see this here for family planning commodities. So significant reduction of 20 to 5.8 in October 2018. So on average, $5.4 per health facility, and in the control health zone that remained more or less stable, increased slightly. We also saw a significant reduction in last mile transportation costs for medicines that were made available through the vertical health programs, because after 2 or 3 months, the health facilities asked not only to work with family planning commodities in the IPM model, but also to add some of the other products that were part of the vertical programs and that were provided free of charge to the population. So that also resulted in a further reduction of the distribution costs, both for family planning commodities and for the medicines. Next slide, please. So the results of this have been improved availability, reduction of excess stock and less expiries, also redeployment that have been prevented, and lower transportation costs. The thing is that with regards to and in terms of sustainability, that has been improved also, partly because of lower transportation costs, but also involvement of the community in the logistic processes. Thank you. Next slide, please. Thank you very much.
Thank you so much to all of the presenters, Frank, Branwen, and Sarah. This was fabulous, really great. It was so interesting to see how the Branwen and Frank, how you sort of brought to life some of the recommendations that were in the advocacy brief. We have quite a few questions, and we have about 18 minutes remaining. So one thing I just wanted to point out, after this webinar, we will be sharing out the recording of the webinar along with the individual or combined presentations of everyone. There were a couple of requests for materials, some in the chat. I saw, for example, Frank, you had mentioned doing a rapid analysis of the supply chain. So someone had asked if you would be able to share that tool. I had a question for Branwen about whether they would be able to share the evaluation report. And I think maybe what we'll do is go through the questions just as they came in. Some of the questions can be answered quite quickly. So I may go by presenter and just ask some of the quicker questions. And then we can leave the more meatier one to be discussed later. So if we back up to Branwen, One of the questions was around what are the supplies that are pre-positioned? There was some, Danny German from UNFPA answered some of the items in the dignity kits, but were there other supplies that were presented? And another question sort of related, the kits that are distributed, are they distributed regularly in countries irrespective of the crisis? Other questions, is there any delay in getting products into the country from pre-positioned points? Or is there a waiver because they are UN goods and it's all worked out in advance? Is everything handed off at the central level? Are the distributions reliant on the government to distribute at lower levels? A larger question is, to what extent this is most effective as a regional intervention? Would the same principles of preparedness and cost effectiveness apply on a smaller district or community level? So Branwen, maybe, I don't know, please let me know if you want me to repeat some of the questions. Why don't you take maybe, so we have 15 minutes left, maybe 5 minutes?
Sure. Thanks so much, Liz, and thanks for all the great questions. With regards to the evaluation, it will be soon on our website. The evaluation, the full evaluation is about 108 pages long and not particularly digestible. So we're also just finalizing a summary document of the evaluation, both of which will be on our website within the next couple of weeks. And I'll include the link to that in the chat box and once I finish answering these questions. Apologies, yes, I said GBV supplies. The Regional Prepositioning Initiative is focused on integrated sexual and reproductive health and gender-based violence response in line with UNFPA's mandate. The supplies that we pre-position for gender-based violence are to both prevent and respond to gender-based violence. So that includes, clinical management of rape treatment kits. It includes tents that you would use to create women-friendly spaces. One thing it's obviously important to remember in an emergency is that the physical structures that services are delivered in are often destroyed. So we have tents that can be used as reproductive health tents or delivery tents, or as women-friendly spaces, or as youth-friendly spaces where gender-based violence survivors can access counselling service or other means. So there's a full range of reproductive health supplies as well. UNFPA is custodian to the interagency reproductive health kits that respond to sexual and reproductive health needs in emergencies, and particularly support the implementation of the minimum initial service package for reproductive health. So we pre-position a range of supplies, and again, it depends on the country context to some degree. With regards to the question about whether kits are distributed irrespective of crisis in priority countries, no, primarily they are always distributed in humanitarian emergencies, and we are operating in priority countries that frequently respond to emergencies. And we're also operating in the Asia Pacific region in a context where governments are strong in leading any humanitarian response. So international humanitarian actors, unlike in other areas of the world, very much have to work with and support the government-led response for any emergency in this region. Having said that, there was a question about whether all kits are handed over, all supplies are handed over at the central level, and no, they're absolutely not. We do primarily work through governments with the Regional Prepositioning Initiative, but in many contexts that is not possible, particularly thinking about some of the protracted crisis situations in the region where governments may be exacerbating or contributing to the protracted crisis. So we're looking at situations where we're supporting other humanitarian actors, NGOs, Red Cross, other implementing partners civil society organizations, local partners. It really depends very much on what context we are working in. The question about the effectiveness of it as a regional intervention, I think that's a really interesting one. In terms of some of the benefits that we have found with UNFPA, I don't know that they would be as beneficial if you were looking at pre-positioning at a district or lower level. Part of that is because you need to think carefully about the frequency of emergencies that you're responding to. And in this region, while, say, Indonesia experiencing lots and lots of different flooding, it may be that a particular region doesn't experience flooding, and so you've got a higher risk of those supplies expiring. At the same time, there is a cost associated with the pre-positioning and management of these supplies. For us at the moment, with the Regional Pre-Positioning Initiative, with supplies pre-positioned in the 11 priority countries, as well as in the regional hubs, we spend approximately $55,000 a year on warehousing and insurance costs. Now, that's not that much when you think about that we've saved $250,000 in terms of freight costs. So we think it's still cost effective, but each point where you have supplies pre-positioned is adding to those costs. Having said that, in some countries we are pre-positioning at the subnational level, including in Myanmar, as I mentioned, where there are challenges sometimes in terms of humanitarian access. Having those supplies as close as possible in some of those other states is preferable to having them in the warehouse in Yangon. I think that's all my time, isn't it? Yeah, I'll leave it there. Thanks, Liz.
Thank you so much.
The chat.
Great. Now, so there are quite a few questions for Frank. I will save Sarah for last. Frank, the first question is, in a humanitarian situation, security systems often lose their effectiveness. And so keeping a quantity of medicines could expose them to theft or damage. What measures have been put in place to avoid the loss of medicines? Another question is about the experience that, and I guess this is really for others as well, so jump in others after Frank finishes, what this experience with working on supply chain issues alongside national HIV programs. Since often someone referenced the fact that often I think Frank, you did we have vertical programs, and so we work in these silos. Frank, could you perhaps define the distribution rounds a bit more? Is it just a monthly distribution schedule where each health facility is assigned a month? Also, a question about community volunteers. I think they're the IPMs, how they were compensated for their services. And finally, there was a question that I think Layla had responded to in the chat about if you could comment on the specific or core elements that are needed to be part of quantification and forecasting of supplies for humanitarian need. And are there differences when you're forecasting between humanitarian or sort of more stable settings? So Frank, if you want to take maybe the next 5 minutes or 4 or 5 minutes to answer, that would be great.
Okay, thank you very much. Thank you very much for all the questions. Regarding loss of medicine, that is, well, in the interventions that we have been doing, we have not been confronted that much with loss of medicine between the level of the district and the health facility. where we see that more often, but that is not in, so regarding, let's say, family planning commodities, there has been, as far as I know, in our projects, there have been hardly any products that have been missing. And in the informed push model that we have been, that we are using, and that we have been implementing, the products, they are being prepared and already bundled at the level of the health zone for the various health facilities that belong to the same distribution route. So, and that is generally done on a motor taxi. So these for these 5 health facilities, it is the representative, the IPM focal point, the representative of the community, together with the motor taxi, who is accompanying the goods and is also delivering them and making sure that all the documentation, the checking and the documentation is being done. CODESA also has for each health facility somebody who is representing CODESA and checks together with the head nurse if the products that are being received at the level of the health facility correspond also with the delivery node. So there is in fact a whole system in place of really taking care of integrity of the supplies from health zone to health facilities under this system. Where we see, that's what we have seen, but not in our program, but what we have heard also, is that particularly when it comes to nutrition products that are used for children, there we see that products are being, that products are not arriving where they should, and that they are being resold. But in medicines, we have not seen that. Then then there was the question on the distribution rounds. That is 1 time a month. So at the beginning of each month, all the data are being transported from health facilities to the health zone. And a few days later, when everything has been checked and prepared, transport is being prepared, and then the transportation takes place from the health zone to the health facilities. The volunteers of the volunteers are basically, they are not compensated. What we do is that we are making sure that they can have their meetings. So we are ensuring that amongst the various IPM focal points and the health zone and health facilities, meetings can be held. And so those are facilitated, but that is basically it. And what we do is that we are providing support to the health zones in order to take care of the distribution of these products. Let's see. Then there was the quantification, the aspect of quantification. Quantification is generally in humanitarian work, and that we have seen, for instance, for the SGBV kids, when we worked in the project together with UNFPA, is that we have in fact identified a number of health facilities within a health zone that were actually designated for SGBV care. And so there, based on historical data on the one hand, so we have quantified, and quantification is also done if we do not have more specific data on the population method. So it's not an easy thing to actually quantify if you are not having, let's say, a close idea on what is going on in the health facility. So it is very often, it is done at the level of the health zone with knowledge of what is going on in the health zone, and based on that, quantification is being done. Did I miss out, or have I covered everything?
I think you hit everything.
Okay.
Thank you. It's impressive,
Thank you.
both of you, answering all those questions in 5 minutes. Just one last question I'm going to throw out to Sarah, just to something to leave us this thought in our head as we leave. Sarah, you had mentioned the need for collective action to develop and implement strategic solutions for bridging the humanitarian development gap to build resilient supply chains. Can you say something about how RHSC and IWAG members might take collective action? What are some things we could do?
Yeah, thanks, Liz. So there are quite a number of ways that folks can engage, places to kind of slot in. So I'll first mention that IWAG and RHSC have together formed a community of practice that aims to increase the continuity of access to SRH supplies in the humanitarian development nexus. And that community of practice has 3 objectives. One is to learn and share with each other across the humanitarian and development sectors on improving access to supplies. The second is really around coordinating and collaborating on shared advocacy and technical objectives. And the third objective is to advance bigger picture changes in institutional structures and practices to break down some of these funding and implementation silos. So I think that's one place that would be great to slow to. And that group has quarterly calls. This webinar is actually taking the place of our quarterly call this quarter. So all of you are welcome to join. The 54 people still on the line must be our most loyal. So please do reach out to me or anyone else who was doing this webinar if you'd like to join that community of practice. And then there are separate groups within both IWAG and RHSC that folks who are members of either of those coalitions can join. The IWAG Supplies Group and several within RHSC that include some focus on humanitarian settings, especially the advocacy and accountability and the system strengthening working groups. So many places where you can continue these conversations. Thank you so much to all of you for joining, and thanks, Liz, for moderating.
Thank you, everyone. This was great. Have a great rest of your day.
Thank you all for your time.
Thank you for having us.